This is a talk I gave at Anna a couple years ago on what surgeons continue to miss about the throwing shoulder. And so here are the people that deserve the credit. Our experience has been with the Rockies. Here's one. So on the lower right is internal impingement in the throwing shoulder, where the superior labrum and glenoid, as they go into external rotation, abduction, extension, impinge against the undersurface of the rotator cuff, more posterior to where the normal impingement of near is. And that's critical to understand, and people don't understand that. I think they miss it. Because when we see a full thickness tear in a professional pitcher, is it this tear that goes through? And it's rare for that tear to go through to full. I've seen two I know that internal impingement went through to full thickness. That's why we leave them alone. However, in the impingement area, as you know, once you get impingement and a small tear, it gets bigger. We talked about that last night. I believe those are the ones that Jimmy Andrews and Masway published on full thickness rotator cuff tears in the throwing athlete. So that's something to keep straight. Now this is how we measure. So we've gone over this. So you can see on the right slide, thumb on the coracoid. So when the internal rotation is done by, that's probably Chuck's hairy arm. Is that your arm, Chuck? But he doesn't have so much hair on his head, but he has it on his body. But that's okay. Got to have it somewhere. So, and then Ellen is measuring the amount of internal rotation. When that coracoid moves, that's when to stop. So you can, these measures can be wild if you don't follow rules. And similarly, when you go into external rotation, when the coracoid moves, we stop. So we should measure that. And then what we want to know is we want to know about posterior tightness. You remember, so we do the horizontal crossed arm. Lots of surgeons don't know how to do that or what to do. And we've already alluded to that. So they should come to at least neutral, if not more across, which means they're not tight posteriorly. If they're tight posteriorly, they don't even come to neutral. And we measure that. Chuck's holding the scapula on the table, so we have a measure of that. But this is core. So everybody, we really need to assess core. And there are ways to do that. And as fellows, you need to get down to therapy. You need to work with Chuck and Ellen and look at core measurements and how we analyze all this. It's frequent that pitchers have a weak core. And we work hard on the core. If you ask a professional pitcher, and I've asked many of them, where do you get your velocity from? What will they say, Jared? Core. Yeah. Where do you get your velocity? They just go like that. So it's not up here. The arm is for control of the ball in the socket, for fine-tuning performance, but not for velocity, relatively speaking. That plays a role, of course. So anyway, we assess core, stepping up and stepping down, and we need to know how to do that. Surgeons don't know how to do it very well. That's one of the things I think they don't know. And then we've talked a lot about this, but to understand motion in the shoulder, external and internal and total arc, we need to know how much retrotorsion is there. More retrotorsion, therefore greater external, less retrotorsion, less external rotation, and more internal rotation. So that all fits in, and it plays a critical role. And then we talked about this, that the development of retrotorsion is just slowing down antitorsion in utero and as we develop youth people. And the forces are such that they don't increase retrotorsion, they slow down the development of antitorsion. So hopefully you'll grasp that concept. And then this is the one, Sabek's model that I think we like a lot, which we don't understand. And here's the other, and Mike alluded to this. So this is, patients have little slap tears, they have little internal impingement with undersurface cuff tearing. They have all these things. That probably helps them throw. But at some point, it crosses over to become pathological and no longer helps them to throw. So then we're going to shut them down and hopefully rehab them. Trying to operate to fix those problems is a challenge. And so adaptations can cross over to become symptomatic pathological. So Mike was, maybe this is a good time, Mike was alluding to the fact that if you put your arm up in this position, externally rotate, a thrower will complain of pain. And that's because we're creating the internal impingement posteriorly, causing internal impingement. Hurts. So what we do is we take the upper arm and we push it back. That's called relocation, and we get more external rotation with less pain because we take that internal impingement away from being impinged. And that's called a relocation test, and it's for pain. It's not for instability, but you can do it for instability if you wish, just define your terms. But normally it's a test for pain, that Gilles Walsh and Frank Jobe taught us to do. Anyway, when we examine them at the end of the season and examine the pitchers, they all have scapular winging. They all have pain with external rotation abduction. I mean, they all have loss of motion. They all have everything, but they pitch and they get through it all, and it's not pathological, but it's of concern. We spend a lot of time on, Doug was saying last night, on the scapula to make sure it works properly, because they have the scapular dyskinesia, and that's a problem. And so this is the arc that we talked about, that you know, same arc on each side, greater external, less internal on the throwing side. And we showed you how we measure all that. And we talked about GERD, we've defined it, and the reason I'm defining it again is Chuck's going to be mean to me, he's going to be mad at me here, because he gave a talk at a recent meeting. It was a great talk, but at the end of the talk I only asked him one question. And I said, would you just elaborate a little bit on clearly defining GERD for the audience, so that they know it's a disproportionate loss of interest? So he clarified. Now, I thought it wasn't clear in his talk, and that gave him a chance to clarify, but in his future talks, then they'll be clearer. And GERD's pretty common, and probably is not all that reliable as an isolated injury. So if somebody says, you got GERD, you got to do a posterior release, that's probably not true. It changes dramatically, and it can be treated by and large. I think I've done 2 or 3 posterior releases over the years, one in a tennis player, actually. And we talked about this, that Pearson coefficient, that the retrotorsion is related more to loss of internal rotation, less relatively to gain in external rotation, which is more soft tissue. That's why I think soft tissue is the start of all of this and we've talked about this already. And then we talk about the failure rate with all this, that surgeons seem to think they can operate on the shoulder and fix it. Well, actually you can't. But this is one that's interesting. This is Jimmy Andrews' study, that he applied heat indiscriminately to everybody, every shoulder he operated on. So most of them were probably sliding forward anteriorly. He didn't document that in his paper. Dougie and I always examined that carefully. But he just applied heat, and he took his results from 67 to 90%. And yet we've thrown heat out with the baby out with the bath water. So we do some suturing. But heat was great for those things, and then we've already talked about that. So this is a scapular dyskinesia. There's Chuck with his hair. And looking at the scapula, if you look at it,